We will now move on to our second keynote speaker for today, Dr. Vivian Winkler. She's a psychiatrist and psychotherapist who has collaborated on several clinical trials at the National Institute of Mental Health, such as COMPASS, PsyCat-1, comparing psilocybin and ketamine, which was mentioned in a previous lecture. And she specializes in personality disorders, treating personality disorders, and dialectic behavioral therapy. Among actually a lot of other things, maybe I will just let you introduce yourself. Please welcome Vivian Winkler.
Thank you, Alan, for introducing me, and thanks, uniMIND, for inviting me here. So I'm also from the National Institute of Mental Health. I'm a clinician there, a psychiatrist, and I'm a therapist as well. I work in the team of Tomáš, who spoke before me. He's my boss, actually, and I work as a clinician and therapist on the clinical trials that we're doing there. And yes, as Alan mentioned, I have been involved in the ketamine study, in the COMPASS study, and mostly I have worked on the psychiat-1 study, which I'm going to tell you about. And I'm not so much involved in research at the moment because I am very focused on clinical work and on finishing my education as a psychiatrist. So I was a medical student not too long ago. And actually, I got into psychedelic research because I was very interested, and I participated in conferences, and we organized some conferences here in Prague while I was a medical student, and that's how I met Tomáš and Jirka Horáček, and that's how I managed to get into NUTS, which I was very happy about. So I've been there, and my talk will be from more of a clinical and therapeutic perspective. So I will first tell you something about the study design, how this study is looking, so you get an idea of how the actual study is conducted, and then I will give you some insights that I've had as a clinician and therapist from the study. So this is where the study is taking place. It's the building of our institute, and this is the principal investigator of the study who actually made it all happen, Tomáš. So thank you, Tomáš, for putting so much effort into it and making it possible for the rest of us to work on it. So how is the study designed, and what are our objectives? So it's a high-quality research study, so it's a randomized, double-blinded, placebo-controlled phase 2 trial. We are comparing psilocybin, 25 milligrams, so that's quite a potent high dose, to 250 milligrams of ketamine, and the placebo is midazolam, 5 milligrams. It's a benzodiazepine, so it's a medication that has some psychoactive effect after intake, but it's not. We know that it's definitely doesn't have a lasting antidepressant effect. In this trial, we only give one-time administration of the study medication, so it's double-blinded. So neither us, as the researchers or clinicians, therapists, nor the participants knows which of these three substances the person will get. The administration is accompanied by psychological support. That means each participant is assigned 2 study therapists who conduct with them 2 preparatory meetings before the session itself. Then there is the dosing session, which takes place in our dosing room, which you saw already in Tomáš's presentation. And then there is 2 integration sessions. One is directly after the dosing session, so on the same day, and the another one is a week later. After the dosing, the patients remain at the hospital. We have a clinic at the National Institute of Mental Health, so they remain at the inpatient unit for 14 days for observation and for study procedures. So it was also a requirement of the SÚKL, which is the Czech pharmacological agency. They required this hospitalization because it was the first trial with actual patients. We also taper them off their antidepressant medication. So there was some worry they might get worse after tapering off their medication, what's going to happen to them after the dosing. So we weren't allowed to conduct an outpatient study. So there's this 14-day hospital stay for the patients involved, which is sometimes quite a complication. And this is the study timeline, so how it goes. We are pre-screening patients first, looking for people who are eligible for the study. We check if they meet the inclusion-exclusion criteria. I'm not going into detail into our inclusion-exclusion criteria, but the inclusion criteria it's for adults, it's for people with treatment-resistant depression. That means people who have been depressed for at least 3 months, not more than 2 years, and they have tried 2 adequate treatments. Adequate treatment is either an antidepressant in a sufficient dose for at least 6 weeks, or at least 6 weeks of psychotherapy. So both are considered adequate treatments. If they have failed this during their current episode, then they're eligible for our study. They should also be able to taper off their antidepressant medications and not meet the exclusion criteria, which are mainly some history of psychosis in the past or in their close relatives, and some physical comorbidities like high blood pressure, untreated glaucoma, untreated diabetes, and so on. If they pass the screening, they're invited to the pre-screening. They're invited to the screening where we sign the informed consent with them. They go through we explain them the study procedures. We confirm the exclusion criteria by drawing blood tests, doing the first fMRI, and then they start preparing for the dosing session. So we plan the tapering of their antidepressant medications. For some people, it's their treatment resistance, so when they taper off, they don't get much worse. They say it's the same. For some people, they do get worse, so we are in contact with them during this time. They meet their therapists. They have the preparation session where they discuss where they're coming from, what's the context of their life situation, what they expect from the dosing session, and we prepare them for the dosing session. It's not really therapy; it's more to create a good setting for the dosing day itself. So it's more this psychological support model. They also come up with an intention for the dosing. They get to see the room, to see the bed, to experience the setting, so they're familiar with it. They try the headphones, they try the eye mask, and then they come for a day before the dosing. They come to NUTS, where we take them to the hospital department. On day 1, they have their dosing session. Just wonder. Yeah. So we're. Oops. Yeah, so this is in English, so you understand. After the dosing, there is the integration right after. Then they go back to their room at the hospital ward, and they have several other study visits throughout the next 14 days. Then they're discharged. They have their second integration session a week later, and after discharge from the hospital, they're still coming regularly for visits or remote visits over the phone with us for the next 3 months after their dosing. Then we kind of release them from these frequent follow-ups, and we have one more follow-up 6 months after the dosing and 12 months after the dosing, where we're interested in how they're doing a longer time afterwards. So what's the objectives and hypotheses and parameters that we monitor? What would we actually mainly want to find out with this trial? So we want to verify the rapid antidepressant effect of psilocybin compared to ketamine. We use the MADRS scale. It's a very widely used scale for measuring symptoms and severity of depression. And we measure this 24 hours after a single administration of the study medication. For ketamine, it's already very well confirmed that it has an antidepressant effect. We know that for psilocybin, there are a few big trials that have already been done, especially by Compass, so that there is also some proof of the antidepressant effect, not so much like with ketamine. So we want to verify these effects for both substances and compare them with each other. Also, we have a hypothesis that ketamine and psilocybin will have quite a similar antidepressant effect in the first 24 hours, but we think that it will be both stronger than placebo, and we also think that psilocybin will last longer than ketamine, and that's our key secondary objective, is the duration of the antidepressant effect in the first 2 weeks. So we know that ketamine has a very good antidepressant effect in some people for about a week. For some people, even a longer time. But for most people, it's quite short. So as Tomáš was saying, that's quite inconvenient in clinical practice. So from the trials that there have been with psilocybin, it seems like the effect of psilocybin could last longer. So that's one of what we're really interested in finding out with this study. How will the patients do, the ones who received psilocybin versus ketamine, after 2 weeks, after 3 weeks, after 3 months? We predict that the psilocybin effect will be more significant after 2 weeks, even after one single administration. We are following the patients. As you can see, it's 3, 4, 5, 6, 8, and 12 weeks after the administration, always with this mother scale, also the 6 months and the 1 year. We also administer the mother scale to see how they're doing. And we're also looking for the mother scale is objective, so it means that it's a doctor or a clinician interviewing them and making the assessment. We also give them a quit scale, which is a scale the patients complete themselves. It's how they feel, how their feeling of improvement is. So how has the study progressed so far? We started this study, it's in 2021, so it's been going on for almost 4 years now. We hope to finalize the screening of participants by the end of this year. Our target number of those participants is 60. So you might think 60 participants in 4 years, like that's quite a generous time to get 60 people. To date, we have only dosed 43 people. And it's really been quite a intense journey to get eligible people for these trials, because we have many outpatient psychiatrists are still very skeptical to these treatments and psychedelic therapies in general. So we're not getting many referrals. We really have to look hard for our participants. There's also a lot of stigma still in the population. So young progressive people are usually not stigmatized against psychedelic treatments, but usually they don't really have treatment-resistant depression. So we've had quite a hard time to find eligible patients for our trial, and it's been a hard work for my colleagues who are doing the pre-screening. As you see, we have pre-screened around 2,000 patients. That's people who have contacted us, have been referred to us, and we have had to make an assessment, look at their talk to them and find out if they're eligible or not. So it's a huge number, and out of these, only 63 people have come for screening. That's signing the informed consent. So we have a huge rate of people who don't qualify. So far, we have dosed 43 people. The last dosing was last week, and we hope to finalize find the number of 60 this year. So lessons learned. These are not research results yet. We obviously haven't completed the study, so we don't have results yet. But this is like my subjective impressions as being a study clinician and therapist on the trial. What have I taken away from this so far? So it seems that really psilocybin 25 milligrams and ketamine 250 milligrams, which are quite high, full psychoactive doses, are very safe to be administered in a clinical setting when a good safety protocol is being followed. We have never had need for any rescue medication. When I've been a study clinician, I'm always on call for the therapists. I give them the capsules of the medication in the morning, I check the patient, and then I leave them with the therapists in the therapy room, and then I come at the end of the session. I'm always on call. If there is some problem, some complications, we have rescue medications available, but I've never been called. Everything has been managed by the therapists and the participants. There have been some adverse events connected to the sessions, but they have been mostly mild and transient. We haven't had any. We have had some serious adverse events, because even prolonging hospitalization of patients counts as a serious adverse event. But that's adverse events connected to the study, not really to the actual dosing session. So it really seems that even these high dose psychedelic doses are safe in a protected environment. They're safe, but psychedelic journeys can be very challenging and unpleasant for some participants. We have had people who have had quite pleasant journeys. It's been very relaxing. For some people, very ecstatic. For some people, it has been a very hard time being there. Difficult emotions come up, feelings of losing control, feelings of being overwhelmed by what is coming up. It's also difficult for the therapists to be there. Some patients go into themselves a lot. Some people want to talk a lot. So it really requires people who are experienced as therapists and as clinicians, and a good setting and a safe setting is important for these journeys, because they sometimes can get really deep and things can come up that can be very challenging to process. most challenging for us as therapists and also for the patients have been the placebo or or I would rather say low intensity experiences, because it's double blinded, so we don't know, and in some cases it's really hard to say. But usually participants are worried in advance. They're worried, will I get a placebo? They don't want to get placebo. On the other hand, they're worried the experience might be too intense. So it's like it will be too intense or it's not going to be intense enough. And too intense, usually we can deal with quite well. It's not too intense. It can be very intense, but participants are usually also appreciative of the intense experiences. The great disappointment comes in when it's a placebo situation. So I think that's something that we need for good quality research, but in these trials, it's really difficult as a therapist to sit there with someone who's going through all these study procedures and then they get an experience that is disappointing in some way for them. Also in this trial, it's quite unpleasant, but because of financial reasons, we don't have an open label branch. So these people get only one single chance to get a session, and a third of patients inevitably will get the placebo, and they don't get a second chance of having an active a session with an active substance. A psychiatric ward is not a great place for afterglow and integration. We have been dealing as a study clinician and a therapist. I've been dealing a lot with people who say that after these experiences, they would like to go out in nature. They would like to spend a lot of time walking, being on their own, integrating their experience. And at the psychiatric ward, there is a lot of the treatment happens by giving the people a tight schedule, so they have to wake up in the morning, go and do the program with the other patients, which is very good for psychiatric patients and depressed patients, but it's quite tough, especially in the days after the dosing session. And we haven't been. We're kind of always looking for a way to be flexible around our patients, but they have to keep the rules of the psychiatric ward. So that's been a challenge for us. So I think for future studies, if we could do without this hospital stay, and I think the COMPASS study that's running now, it's an outpatient study, so I think that's much better. An integration after a week seems like quite a long time, especially when people are in this hospital ward where in a week lots of things occur, and sometimes they're full of other experiences that have happened since the dosing session. There's been a weekend, they have been out for the weekend. So we get back to the session a week later, but for some people it's already it seems already quite distant. So what's been interesting from my perspective as a therapist, there was these trials from John Hopkins University where they said that a 20 milligram psilocybin dose quite reliably produces mystical experiences in people, and that these mystical experiences are connected to the outcomes, to the therapeutic effects of psilocybin. From my perspective, I mean, I haven't evaluated again the results. Our participants get this mystical experience questionnaire, which they complete. So we will have to look at the numbers. But from my experience, they haven't talked about mystical experiences much. It seems like it's something that doesn't come up so frequently. I wonder if it's because Czech Republic is quite an atheist country, so very few of our patients are coming from Christian or religious backgrounds. So I wonder if that could be one reason, or we definitely see more of these experiences in the other trial that we have with cancer patients. So it's maybe also these existential distress topics that are closer to looking for spirituality and for spiritual answers in these experiences. And for the patients in this treatment-resistant trial, it hasn't been such a common topic like I expected. Some participants improve without significant insights. I have experienced this a few times, that people just say they have been just floating in a nice space, get a sense of really deep relaxation, nothing really awe-inspiring, no meetings with God, no ego dissolution, and still they get much better afterwards. So that's coming back to the question, do the psychedelic effects matter? For sure, for some people, the experiences they have had have been very valuable therapeutically, and we've been able to work with it. For some people, it's not so much to really integrate afterwards, but they still get better. The experiences are very individual and different. Just as an example, here are two actual pictures that participants have allowed me to take a picture of and share. The first one is it's from a participant who said after the session that it was like it was like a fast course in life wisdom. And he wrote down these 30 points as part of his integration, which is like lessons, take-home lessons for his life, how he should change things in his life. And it's written too small for you to see, I think, but there's things like I should go to bed early, I should rest enough, I shouldn't care so much about what other people think. And it's kind of obvious things for people who, or obvious topics that come up in therapy, but this man actually, he was a very ordinary guy from a small Czech village, never touched by any therapy. And we were quite surprised that all these like insights came during the experience, and he actually wrote them all down. And he had, it was a lot for him to process and take home with. And it was things that he came up with. It was not told by someone to him. So, yeah, he had there things like spend more time with my parents, with my children. Don't drink beer so much. Yeah. I think it was all very valuable advice. Then this other picture, it's from a participant who had so this was like the type of experiences where it's very much about insights. The other one was very experiential. He had lots of inner visions and like very vivid imagery. And he had this moment of transformation where he was describing that during the trip he was like being an embryo, and he was putting himself together, and he was kind of choosing the parts of himself, what he wants to be in the future. So he put in himself parts that he wants to be, and he left other parts out, like a very strong voice of inner critique. So he left that out. And then he said he experienced his birth. So you can see the birth canal that he came out of. And then he said he was flying out of there, and he turned around and he saw these beautiful ladies in bikinis behind him, and he was like, yeah, life is going to be good after this. So just being born into this new joy, I really like that. Yeah, and what I take away from it as well, one psychedelic session is not a wonder bullet, definitely not for most people. We have seen great variability in participants' trajectories. Some of them get better for a short time, some of them for a longer time. They get worse afterwards, then they get better. When I contact them after a year, it doesn't have to do anything with the psychedelic session. So psychedelic experiences can be very powerful and impactful, but they're part of the greater journey of the participant and their lives, and there is a big influence of other circumstances in their lives. And I think what I'm taking away from it as for the future of psychedelic therapy is that we should expand the idea of integration, but not in the sense of integrating only the psychedelic experience, but integrating psychedelic experiences into people's lives and therapeutic journeys. So I like the second picture of like having a psychedelic experience is just one of the things that can contribute to you making progress on your therapeutic journey, and not a goal or the one and only significant thing in itself. Yes, and I will conclude with my last slide, which is that in clinical trials, we have a very specific set and setting for psychedelic therapies. I think we and our participants are missing out on many aspects. I think Tomáš, in this movie that you will see today, I'm making a little advertisement for it. I really like this idea that they went to see what does it do, how is it different when we go and see psychedelics in naturalistic environments. This is the traditional environment. There's other environments that have their also their risks and possibilities as well. But the clinical trial, in many ways, is very limited. We are limited in how individual and personalized we can approach our participants. It's a trial, we need it for the quality of the data, but it's a compromise that we have to make. Also, the therapist-participant relationship does become very intimate in psychedelic sessions. Like, you really experience something out of the ordinary. And I think it requires special attention to maintain boundaries and safety. As we have seen in the MDMA trial, even though it was a trial, like therapists did transgress, and it's when you are, I as a therapist being there in those sessions, really experience that. Like when there is a profound experience, the atmosphere in the room changes very much, and I think it's good that we're there together, and it's just something very out of the ordinary, even for a therapist. We do get intimate we do explore a lot of emotions, but in regular therapy sessions, but in psychedelic-assisted therapies, it's a whole other level. And it's extremely rewarding to be able to witness how profound psychedelic treatments can be when it helps and when it works well. So I'm very grateful that I can be involved in these trials and that I'm able to do this work. And yes, this is the website of our trial. If you want to have a look, we have a website where we can, it's in Czech, but it says it's mainly for participants if they're interested. So that was my talk. Thank you.
Thank you, Vivian. Any questions to Vivian? Yes.
Hi. I was wondering if you could just speak a little bit to the challenges of blinding these kinds of studies, because I was wondering specifically if one of the pre-selection criteria is that these people be psychedelically naive, because I feel like if you are not, it would be almost impossible to blind the difference between a ketamine and psilocybin, and especially midazolam experience. And if, as you spoke a little bit to, how this sort of potential disappointment of getting the placebo, which I think would be quite obvious even to a psychedelically naive person, could then affect the outcomes of a study like this.
Yeah, I think the placebo question, it's a question that's around psychedelic research for obvious reasons. We do want to have double-blinded trials in order to be able to compare against something, because we know the placebo effect is powerful, and yet how to blind these really profound, powerful experiences. We have chosen midazolam because it does alter consciousness in some way. We have a questionnaire for this where we ask participants and therapists after the session what they think they got, which substance. So we will analyze this afterwards to see how well did the blinding work. So that's a question that we're looking forward to have the answer as well. And I have to say that for us as therapists, it's very often hard to say which one was it exactly. So that's sometimes we have a guess and we feel like it's more this way or that way, and sometimes it's quite difficult to say. I have to say, it's more difficult to say than I expected. Yeah.
Thank you.
I just wanted to ask, what type of psilocybin are you using? Are you using whole mushrooms or synthetic psilocybin without the tryptamines and the other compounds? In Canada, certain patients, palliative patients, can be approved for special access to psilocybin, but the rules are very rigid, and the clinicians are complaining that the dosing is set, and it's also synthetic psilocybin that may not have the same effect. So that's where the question's coming from.
Yeah, we're using synthetic psilocybin. We have it delivered by USONA. It's an American NGO that provides GMP-certified psilocybin for clinical trials. So it's synthesized, and we get it in capsules. Our participants often ask, so are we going to get the mushrooms? No mushrooms here. They still often say that, some of them, that they encountered the mushroom spirit during the experience. So that's an interesting thing that comes up. Well, we don't know what they got, right? But the mushroom spirit shows up, so it's kind of, who knows? And I just saw the movie Dosed yesterday, which was, we had a cinema screening where it's set in Canada where a woman gets psychedelic mushrooms. Yeah, so I think there is different, it's a really interesting question what the difference would be. Yeah, then I think when they Wesson brought to Maria Sabina, the Mexican shaman who gave them the psilocybin mushrooms first, he gave her synthetic psilocybin and asked her, so is it the same? And she said, yes, this is the mushroom spirit. So, yeah, but that's a nice story.
Yeah, thanks for your talk. This might be a question more for us just to have a discussion about after your talk, but I'm curious to your opinion on ketamine versus psilocybin in terms of the therapeutic utility, and just from your own personal experiences or opinions, what you think, how they would be distinct or similar.
It's hard for me to say because this is it's in this trial I don't know which one they got. I do work with ketamine off-label at NIMH. We give it as a treatment for treatment-resistant depression, and I have to say I was more skeptical. I thought psilocybin is definitely the better thing, and ketamine is just a replacement until we can have legal psilocybin. But some people have really profound journeys with ketamine even. For some people, it's just a relaxing experience and they feel better afterwards. And some people have very deep journeys that they go on. So I think it's individual, and ketamine definitely can be used for deep psychotherapeutic work.
Thank you for your questions, and thanks a lot, Vivian.